Hello everyone and welcome to the Scleral Lens Education Society webinar. My name is Stephanie Wu and I have the honor of helping out with the Scleral Lens webinar. Today the topic is going to be get all of your scleral lens questions answered. We're featuring Doctors Jason Jedlicka, Brooke Messer, and Longis Michaud. And just a plug for the Scleral Lens Society, we have a website. It's sclerallens.org. It's a nonprofit organization. And after this webinar, this will be recorded and you can watch it on our website in about 1 or 2 weeks. So just so we have some housekeeping here, if you look on the right-hand side of your screen, you will have a little control panel, and you can type in some questions where that big yellow arrow is that I have showing where you can type a question in, and then just submit it. And what we'll do at the end of each segment, I'm going to answer some questions as they relate to each topic. If we don't get to your question at the end, we're going to try to email everyone who didn't get their questions answered. You can minimize the control panel so it's out of your view if you want to. If the webinar screen is lost, go ahead and click on the blue flower icon that's on your taskbar on your computer. And then if you have any technical issues while you're online, please call the number that you see there. I'll just give you just a couple seconds to write down that number in case you lose contact. Perfect. So tonight we have a great panel of expert lens fitters. And we're going to talk about some hot topics. Now these topics are some of the most frequently asked questions that we get on the sclerallens.org website. So we're going to have all 3 panelists discuss in detail each of these topics. If you have any specific questions during the webinar about these topics, please type them into the question box and I will ask them to the panelists as soon as we finish that section. So the first issue is lens fogging. And I would like to start with Dr. Jason Jedlicka. Will you please go over lens fogging, what it is, and what you personally do to take care of this?
Well, Stephanie, I think there's 2 different kinds of fogging we might be talking about here. There's the fogging that's on the surface of the lens from poor wetting, and there's the fogging that comes under the lens from accumulation in the tear reservoir. And I think we're talking more about the latter, which is the lower right picture you see where the lens has particulate debris underneath the contact lens, underneath the scleral lens. And this is a question that I'm asked frequently. I just had someone ask me about this a few days ago. What do you do when you have this accumulation of debris underneath the lens in the tear reservoir? And to me, I typically suggest to the fitter that somewhere along the way they've got a loose edge or an area of the scleral lens where the scleral profile is not flush with the sclera of the eye. So you may see this in a patient who's got a toric sclera and you have a spherical lens where there's areas where the sclera and the lens are not well aligned, and this is going to allow for tear exchange in an unhealthy way, which allows matter from the tear layer to sneak underneath the contact lens and accumulate. So my first recommendation would be to look for areas where you have a loose edge fit, maybe by putting some fluorescein in the eye and watching for areas where the fluorescein sneaks underneath the contact readily, and then to look again and see if there's a way that you can somehow bring the lens and the eye into better alignment to stop that flow of debris and matter underneath the contact lens.
Thank you, Jason. And now I'd like to ask Dr. Brooke Messer about your thoughts.
can you, sorry, hi everyone, I think I had myself on mute there, but in regards to lens fogging, I think that Dr. Jedlicka's comments are spot on. I have learned in the past couple years that my fogging has decreased since I have switched into fitting more peripheral curved toric scleral lenses. And if the patient comes in with the lens on and they have a foggy tear layer, I do the same thing. I put the fluorescein right over top of the scleral lens and see if it's seeping in anywhere, because I think that if the lens edge is lifting, maybe it's interacting with the epithelium underneath the upper lid and sort of sloughing some cells there that can get underneath that lifted edge. I also think that, trying to think outside the box, something else I have really educated my patients about recently is making sure that all of the solution that they're using is out of the lens before they put the saline in to put it on their eye. Maybe some of the preservatives from, the Boston or Unique pH or whatever they're using is stimulating maybe some mucin production or irritating the surface of the eye while the lens is on. So I will remind them that, completely rinse out the bowl of the lens and then fill it with the saline prior to applying to the eye. And then on this slide, there's a little note about Restasis users, and Restasis helps contribute to the cells that produce mucin. And so there has been talk about, if you have a patient with a very foggy lens, maybe you want to trial and error with decreasing or eliminating their Restasis for a while to see if that improves. But I will say the biggest improvement to my experience with this is the peripheral curved toric sclerals.
Thank you, Brooke. And lastly, Dr. Langis Michaud, will you please explain to us about lens fogging?
Yes, thank you, Stephanie. I think that the very nature of the debris are not really well understood, but preliminary studies made at Pacific University, as well as we did in Montreal in conjunction with the help of our sister school, Canadian School in Waterloo, allowed us to determine that it's mainly mucins and lipids, some debris of cells accumulating in the tear reservoir, and certainly that gives us some clues about the behavior of sterile lenses of the conjunctiva. So the larger the lens is, the more clearance you'll get, and the more chances to develop fogging you'll get also. That means that if you heavily rub the conjunctiva and you disrupt the transmembranial mucin over the goblet cells on the conjunctiva, you'll create a lot of these debris and lipid deposits that will gather in the tear reservoir by negative pressure. As soon as the lens is sinking in the conjunctiva, you create a negative pressure, and anything can go under the surface, but nothing really as a fresh tears production can go under the lens. So the tear mixing is not optimal, and certainly you accumulate debris very rapidly. I saw patients with, after 30 minutes, showing a lot of fogging. So the rationale behind that is to limit the chances for the lipids to migrate in the tear reservoir, and you can do both ways. First, to reduce the clearance, the overall clearance under the surface of the lens, under 300 microns preferably, and secondly, to limit the clearance over the limbus. Again, Pacific University studies prove that if you limit the clearance over the limbus, you limit heavily the amount of debris under the lens. So I never saw debris or fogging with mini scleral lenses or with smaller diameter scleral lenses, 15 millimeter or 15.5, which rely on limited clearance as well. If it's only happening when you use larger lenses, and again on patients who are already developing a lot of lipid, you have to look at blepharitis as well, because these patients certainly produce a lot of abnormal debris in their ocular surface, and this is one concern. By the way, in some patients, if you have no other choice than to fit them with high clearance and larger lenses, they will in fact develop less and less debris over time. That happens. So if you're patient and your patient is patient, for some of them the fogging problem and the fogging issue will will clear over time, and certainly it's kind of an adaptation of the ocular surface to this mechanism and or the presence of the sterile lens. So my recommendation would be to go with smaller clearance in general, smaller clearance over the limbus, and to limit a bit the diameter if you have any issue. If you have no choice, use artificial tears. Toric peripheries are certainly a way to go in order to limit the migration of these debris under the lens. I totally agree with what was said before.
Thank you. So I'm going to take a couple questions from the audience, and sorry if I can't get to all of them. We'll try to address as many as possible. So first, for the three doctors, can you please address tear exchange? A question from Richard Dorer. So can you explain lens fogging and tear exchange and how they might be related?
In fact, this is Langis. We don't know a lot about tear exchange, and we have to consider two things here. Tear exchange means that some new tears will go under the lens after a few times, and to replenish the tear reservoir. And then you have the tear mixing, meaning that the tears that can enter in that reservoir will mix with the content that is already there to create a kind of a new solution under the bowl. So there are very few studies on that, and it's a big concern actually in the industry because we have different opinions on that. Personally, I believe that after the first 30 to 45 minutes after insertion, the lens begins really to sink in the conjunctiva, and you limit heavily the tear exchange. So there's almost few tears entering under the lens, and the few that are entering are really percolating under the surface. And then the mixing is not obvious depending on the type of solution you use. In some patients we use more viscous solution like Refresh Yellow Vis, for example, Hilo or Arigrup, or any kind of viscous solution, and they do not mix well with tears. So this is another problem because you'll create a two faces reservoir at that time that can create some fogging as well.
Okay, thank you, Langis. In the efforts of time, I'd like to move on to the next topic, and we can try to address some of these other questions later in the program. But I want to move on here to cylinder and over-refraction. And Langis, I would like to start with you on your opinions on this topic.
Two things. At the beginning of when we started to fit sterile lenses, we had a lot of cylindrical issues. We thought at that time, as everybody thought, that it was coming from lens flexure. So we tried to increase the thickness of the lenses to alleviate that to occur. And frankly speaking, with mini steriles as well as larger lenses, I didn't get rid of these cylindrical values just by increasing the thickness of the lens, to the point that I'm not recommending that anymore. I think that the over-refraction cylinder in over-refraction comes mainly from the non-symmetrical distribution of the tear reservoir under the lens. So if you design the lens in a way to create a kind of a toric shape tear reservoir, you'll end up with a cylinder in over-refraction. If you change your base curve keeping the same sag value, if you change your peripheries, and ask your lab about that because they are all able to do so for you, certainly it will help you to kind of create a more equilibrated tear reservoir and certainly a more symmetrical across the board over the cornea. So I think that the cylinder is coming mainly from a non-symmetrical tear reservoir. Second thing is obviously the internal astigmatism that comes from the crystalline lens. If you compensate all the corneal cylinder, obviously, if you have a sufficient and significant lens cylinder present in the optical system, you'll end up with that. So the only way at that time is to create a front toric scleral lens, and it's not an easy task to stabilize those lenses. You have to use a larger lens, and certainly with double slab off in order to make the lens very stable on the eye, which is crucial when you try to correct within the front toric surface.
Thank you very much, Langis. Now, Brooke, I would like to go through the next 3 slides, which are yours, and if you can please just elaborate on each slide here.
Okay. So this one here is one of my favorite slides. I included in a ton of scleral lens lectures. And looking at this one, you know, I often show a topography to a patient that has the posterior float of the cornea on it. And so what I will explain to them is I'll show them the anterior float, and I'll say, you know, here is the irregular part of your cornea. And this is the part of your cornea that I can fix with a gas-permeable lens, you know, and most of the time we're talking about a scleral. I'll say that, you know, the irregular astigmatism that comes from your keratoconus or corneal transplant can be fixed by just having GP lens optics because the tear layer negates the irregular astigmatism. Then I will show them the posterior float of their cornea, and I'll point to, you know, what we call the hot spot, or where their cornea is changing. Thanks, Stephanie, for pointing to that. And you know, where their posterior cornea is changing due to the keratoconus or pellucid. And I'll say that, you know, sometimes this can actually produce astigmatism also, or something that limits your best corrected visual acuity. And so I will explain to them that sometimes it produces astigmatism that we can put onto the front of the contact lens, like an F1 toric scleral, but sometimes, you know, that this hotspot actually limits our best corrected acuity. That way, when the patient, you know, has, you know, minor doubling or a little bit of ghosting, when we feel like we've reached the end of the scleral lens fitting, they understand why they can't quite see as well as they hope they can, or they understand what limits their visual acuity. So the next one is, just as we were talking about on the couple previous slides, is determining if lens flexure is actually present. And so whenever I have a patient who has astigmatism in the over-refraction, I often put them in my topographer or at a manual auto-refractor to read the Ks of the lens. And if the Ks are showing some toricity, then I can assume that I have some lens flexure. And at that point, now again with the advancement in how good our toric peripheral sclerals are, I often go that route because many times the lens is bending on the toric sclera, and so then I'll just make my scleral lens toric to more appropriately line with the sclera to eliminate that lens flexure. And again, if, you know, you do the over-keratometry readings of your scleral lens and you see, you know, that there is minimal flexure and there's astigmatism still coming through on the over-refraction, you'll want to rule out some things to determine if it's residual astigmatism. Obviously, you know, if the astigmatism coming through is a consistent amount and at a similar axis through multiple orders and over-refractions, that's a clue that it might be residual astigmatism. Lenticular astigmatism is against the rule most of the time, so you can watch for that. And then again, you won't notice any flexure on the over-keratometry readings.
Thank you, Brooke. Now, Jason, do you have any other last comments about residual astigmatism or cylinder in your over-refraction?
I would just say that, like was already mentioned, if we do have that residual astigmatism coming through, and I'd like to do a topography right over the top of the contact to check and see if it matches the refractive astigmatism. I think it's important, though, that when we do these over Ks or over topographies over the top of our lens looking for flexure, that we don't have the patient hold their eye open nice and wide like we typically do with topography. We want them to be in the most natural state they can, because if they open wide for that map, it's going to alter the flexure that the lids would cause. So I think it can be fairly routine that when we get over-refraction astigmatism through a scleral, I automatically go for topography and I see if it correlates, and if so, again, either changing the lens profile, and again, like Lanji said, changing the center thickness alone isn't always going to resolve flexure. You need to increase the profile of the entire lens a certain amount. But to correct that in the front toric, or if you sense that the lens flexure might be due to, again, the astigmatism, the lids, you can certainly make the landing curves or the scleral zone toric as well. That will reduce the amount of flexure that the lids have, because it will actually cause the lens to align to the sclera better, and it will have less propensity to flex. So I think there's different ways to deal with it, and certainly I feel much more comfortable at dealing with residual astigmatism now than even a few years ago, as we have really good front toric scleral options, and we have really good scleral zone back toric options to align the lens to the eye better.
Thank you so much, all three panelists. Just a couple questions before we move on to the next topic. Someone asked, what in the heck is double slab off going to do, and why use it?
I can jump on that if you want me to. There's two ways to stabilize a lens, or a couple different ways you can stabilize a lens rotationally so as to allow for the proper correction of the front toric. One is, in some cases, a lab can make the back alignment curves of the back scleral zone toric, and that will then allow, of course, the lens itself to be rotationally stable. And then when a front toric is ground on the front optic zone, it will automatically be stabilized by the back toricity of the scleral zone. However, if you have a back surface of the lens that is spherical, then you need to do something to stabilize that lens. So just like with our soft torics that are double slab off, where the lens is thinner at the 12 and 6 o'clock position and thicker at 3 and 9, so that when we blink, the lens is rotationally stable. This is similar to like the Visticon, the J&J soft toric options. They're using the same method of stabilization. It just allows for, it's another way of stabilizing the lens using a front surface stabilization rather than prism ballasting.
Thank you very much. I'd like to move on to the next topic here. And the next topic is when to RX toric haptics, which has been a very popular thing that lab consultants have wanted a lot of optometrists to do. And Jason, I would like you to read the 2 points that I have on the screen out loud, and if you could comment on that, please.
That's great. It is now known that the sclera is not spherical, but non-rotationally symmetrical. Scleral asymmetry worsens with increasing distance from the corneal limbus. Minor differences between the spherical lens haptic and the sclera may be offset due to the spongy scleral conjunctiva. So I'll comment on it real briefly. There's no question, if you look at anybody who studied scleral shape, we know it's definitely not spherical. In certain cases, it can, again, the sponginess, the softness of the sclera can allow the lens to settle and sink in, and that can be enough in many cases to compensate, especially if the lens has a narrow landing zone. But in other cases, we know that the sclera is more toric, just like the cornea is, and so sometimes we have to compensate for that. So on the second point, some patients have asymmetric scleral anatomy that results in a poor fitting relationship when fit with the scleral lens that has a spherical haptic surface. The lens will have 3 o'clock and 9 o'clock compressions, as well as excessive lift at the 6 o'clock and 12 o'clock positions. In these instances, some manufacturers offer toric back surface haptic, which can dramatically improve the scleral lens's fitting relationship. And I think this is somewhat common. I mean, we all have patients we fitted in scleral lenses that they come back after wearing them for a while and comment that their eye will get a little red at the inner and outer corners. Maybe after the lens is removed it gets red, and yet at the same time we look and superiorly and inferiorly it looks great. And again, just like the cornea is often with the rule, it's not uncommon, I think, to see the sclera have a little bit of a with the rule shape. And so I've gone to using these options more and more commonly as they become more available and easy to fit.
Thank you, Jason. Brooke, do you have any comments?
Not a lot to add to Jason, but I would just encourage everyone to consider utilizing them because they have become such a key tool in my use with Sclerals. Like I said, it not only solves the lens flexure, but it solves the fogging, and it really does reduce the amount of rebound redness that patients have when they take their lenses out at night. And so then they don't worry as much about wearing their Sclerals for the entire day. You know, many times I'll have patients come back, you know, after the first dispense, and they'll be worried about their red eyes at the end of the day when they take their lenses out. And by being able to lift the 3 and 9 o'clock meridian to reduce that, you know, horizontal impingement of the lens, they really feel like, you know, their eyes are doing better in the lenses.
Thank you, Brooke. Longis, do you have any final comments?
Yes, I think that the take-home magic number is certainly 15 millimeter. Based on the anatomical studies made by Eve and their work, we know that outside 15 millimeters from the center of the cornea, so it's 7.5 millimeter each quadrant, we have to deal with a high level of conjunctival toricity. So any Scleral lens inside the 15.5 diameter shouldn't have to be made with toric peripheries, at least, because mainly the conjunctiva is not so toric at that point, but anything larger than 15.5 inevitably should merit your attention, and most of them will have to be designed with toric peripheries. If you look at European data in the literature, up to 80–90% of their lenses are made with toric haptics, and certainly it helps, as other speakers said, to favor the tear flow under the lens and alleviate a lot of problems with that. So it's more respectful for the ocular surface, and certainly the way to go.
Thank you, Longis. Let's take a couple questions from the audience, and I would like the three panelists just to keep your answers to just the minimum. But please, Jason, can you please answer this question? Does Boston XO2 cause more flexure than Boston XO?
I think in theory it should. At the same time, personally, when I feel like I need to fit someone in XO material, that's probably the least of my concerns.
Thank you. Brooke, how much haptic fill do you initially RX?
Nowadays, I usually just ask in terms of steps, and I think that, you know, a 1 flat in the horizontal by a 1 steep in the vertical is not enough to see a big amount of change. So I'm usually making the difference between the two meridians at least 3 to 4 steps.
Thank you. And Longis, what do you do when you are dealing with pingueculas and pterygiums?
In fact, you can do a few things for pingueculas. Depending on how big they are and where they are located, you can try to vault over them, so to expand the size of your lens. That's one thing, and or to modify by quadrant your peripheries according to what you want to do. There are some lenses available with they can decenter a bit their optics, so they can also kind of create a very localized zone of lifting of the lens and the periphery just over the pinguicula, so it helps a lot. You can also notch the lenses, and again, if you want to notch it, you have to stabilize it very carefully, so it's a more complicated design. For pterygium, certainly you have to vault over it, because any kind of rubbing over the pterygium will increase the redness and inflammation, so no choice rather than to just vault over it. So modify your peripheries, your mid-periphery accordingly, and or use more viscous solution just in order to do not touch and never touch that fragile epithelium, and certainly the vascularization, to favor vascularization over there.
Thank you. And Brooke, there's a couple people that are confused about steps, and a lot of they're not sure what a step means.
Sure. Thanks. Yeah, I was thinking about that after I answered also. So as you you know, get to know your company that you're, or the lab that you're working with, you know, the few labs that I like to work with on the Sclerals, they I've learned what one step of change means, and we don't really talk about it in forms of diopters in the periphery of how many millimeters of change or how many diopters of change. And so what I mean by step is just the increments that the lab used to make changes. For example, you know, the Jupiter, the peripheral curves are like a 12.5 and a 14.0 or a 12.5 and a 13.5. You know, most of the time they make steps in half millimeter, so they'll go 12.5 to 13.0 or even 12.5 to 13.5. And so usually when, you know, when I say one step to them, they go a half millimeter flatter or a half millimeter steeper. But again, it's just getting to know the amount of change that your lab uses when they're flattening or steepening in creating a toric haptic. And so what I mean by step is I wouldn't change, you know, the vertical meridian by a half millimeter and in one direction and the horizontal meridian by a half millimeter. I would make larger changes, because those small changes, the lens just sort of settles in and you don't see enough change. So by making, you know, a full millimeter change in the peripheral curve, or even a millimeter and a half in one of those meridians, is where you'll actually start to see some change in the lens fit.
Thank you, Brooke. And last question before we move on, Jason, if you simply change a generally successful fit to include a toric periphery, do you need to expect to change other things like the vault or the power?
Again, theoretically, going to a toric lens, if you're going to make a meridian shallower, what I mean by that is if we've got a tight lens at 3 and 9, so that meridian is going to be flattened or shallowed up to allow for a better fit, then you are going to lose central vault. And you know, typically you may lose 30 microns of central sag. Personally, I'm not fitting a lens where 30 microns is a deal breaker. If I want to vault with 300 or 350, if I lose 30 microns, I guess I don't really care. By the same thing with the power, yeah, if you lose 30 microns of sagittal depth underneath the lens, in theory that might change the prescription of the lens by 1/8 of a diopter. Most of the patients in sclerals aren't going to notice 1/8 of a diopter. So I guess my feeling is I don't worry about the small impact that going toric has on the power or on the clearance centrally.
Thank you, Jason. Let's move on to the next topic now, which is lens deposits. And we had a lot of questions on this, but I think a lot of these will be answered in the next few slides. And Langis, I'd like to start with you, please.
Yes, lens deposits are multifactorial as an occurrence. Certainly we have to look first at the ocular surface itself. If you have a patient with blepharitis, a lot of crusty deposits, meibomian gland dysfunction, abnormal lipid layer, certainly these are issues that have to be dealt with in order to improve the outcome. The second part is certainly the cleaning. Our regular Boston solution or gas perm cleaners are effective habitually with most of these patients, but in some heavy depositors you have to use ProGen from Minicon, for example, in office in order to recommend to your patients. My favorite is certainly to use peroxide solutions. I use a lot of them for my regular gas perm. I use a lot of them for my scleral lenses as well. The new one in the field, the Peroxiclear, offer a wider basket, so it helps for most of the sclerals that we are dealing on a day-to-day basis, and certainly it's an improvement compared to the other peroxide that we had before for gas perm lenses. And in addition, I can use also an enzyme cleaner or a regular cleaner just to add up a bit if I need it. But the ocular surface has to be really looked at and certainly to take care of in order to alleviate deposits. and then the cleaning does the other thing. The material by themselves, if I have really a big issue, I will use a Tyro 97 because the wetting angle is so reduced compared to the Boston XO, but I'm losing some of the oxygen permeability of the material. It's still 97, but it's a thick lens, especially if I use larger clearance, I will penalize the cornea on the long term. So I'm not really a big fan of switching over a lower decay material, but I have no choice, that's the way to go.
Thank you, Langis. And Brooke, do you have any comments?
Just to add to the progent, I really think that regular progenting to the lenses helps keep the lens clean and the surface optimized. You also want to make sure that you're talking to the patient to get into the depth of the bowl of the lens so that no film builds up on the inside, because sometimes they'll forget that. And so make sure you're telling your patients, get your pinky finger in there and clean the back surface of that lens to keep the optical center nice and clear for you.
Thank you. And Jason, any final comments?
I think that it's important to remember that lenses are going to form deposits where they start off with drying. So where the lens surface dries is where deposits will form initially. So we have to make sure, that our lens surface is wettable, and we also want to make sure that the lens isn't vaulting excessively, because the more we vault, the more we push that surface of the lens out from the safety of the lids, the more we're exposing it to evaporative drying, and so we're inviting more deposits. So I also say that if you have a patient who chronically deposits, on top of all the other things which we've obviously talked about, lid hygiene and lid health and ocular health, I would say look and see if there's room to bring that lens a little closer to the eye and decrease the vault.
Thank you very much. And just a couple questions here. Doctor asks, do you all like to use plasma treatments on these lenses or not?
For me, it's a no-brainer that in my lab is always, sending me lenses with the plasma treatment done on every lens, and I found a big difference using these plasma lenses. That it helps, no question. I
agree. I don't see any reason not to, unless you've got somebody who has some particular cleaning habits where that might not be a benefit. But I think especially as we move to using more peroxides and whatnot for cleaning, I think it's kind of a no-brainer too.
Thank you. Dr. Matthews notes, when I use Tyro 97, we get more lens breakage versus Optimum Extra. Do you also see this?
I can't say that I've noticed anything in materials, that close from Tyro to Boston XO or Optimum.
I agree. I haven't seen it, but then again, I don't use Tyro very often, so I don't have a lot of experience with it.
Perfect.
The one thing when it comes to lens breakage is make sure that they support the lens when they take it off the plunger, rather than squeezing the edges. Grab onto the lens from the center. Put one finger on the front and one finger on the back, removing it off the plunger.
Thank you. That's a really good tip. Okay, our next topic here is assessing proper limbal vault. I think this is a rather difficult thing to do when you are a novice fitter. So, any tips or pearls that you all have? I'd like to start with Brooke.
Thanks. Yeah, when I'm really picky about the limbal vault because I think it's a definite factor in patient comfort. And so one is you'll know if you have too little of limbal vault. If the patient comes back saying that, after 3 to 4 hours my lens becomes uncomfortable, it feels like the lens is tight to my eye. And so then, automatically that tells me that I don't have enough limbal clearance and I need to pay extra special attention to that. On the other hand, Too much limbal clearance also causes problems, as we've already talked about, with lens fogging and the tear layer debris and things like that. So the other thing that I always look for is I like to see my fluorescein sheen go just past the limbus, you know, and no more. If I have a very deep fluorescein going way past the limbus, then I know that I have too much limbal clearance, and I can tighten that up to optimize the fit to make sure I don't have too much tear layer around that area. And again, we have to remember that the fluorescein molecules have a certain micron of thickness, and maybe one of the others can help me remember. I think it's like maybe 40 microns or something like that, so that even though we don't see the fluorescein go all the way out, we know that there's clearance because the fluorescein molecule doesn't get all the way out to the edge of the limbal clearance because it's too large.
Yes, thank you, Brooke. And Longis, will you please continue?
Yes, we have to differentiate, as Brooke said, about the central clearance and the limbal clearance. For the central clearance, it's quite obvious that we have to observe under the smaller optic section, possible under white light, to evaluate that, comparing the thickness of the lens itself and the fluorescein layer under the lens. Most of the lenses are made around 300 microns of thickness, so if you expect that as the initial tear reservoir thickness, you have to have a 1-to-1 ratio. Very soon in the process, after 30 minutes, you have to get 2/3 of the thickness in order to provide enough oxygen and to have a proper fit. For the limbal vault, as we said, I prefer to limit the vault over the limbus because of the fogging issues and all that stuff. I have really no concern not seeing a lot of fluorescein over the limbus if at the follow-up I remove the lens and stain the cornea. If I don't see any compression ring, if I don't see any staining at all, you know, there's no real issue for me. I fit thousands of lenses with limited limbal clearance, and never it happened to me to get neovascularization. Neovascularization comes from the fact that you deprive the cornea from oxygen. So if you are too close to the limbus, you provide more oxygen, not fewer. As a mechanical pressure on the stem cells, this is the big concern that we have. There is no real scientific evidence that we create negative stress if we can distribute the weight of the lens over the overall surface of the eye. If you touch on just a single point, if the lens is centered, for example, and you have a touch on a single quadrant, then you have a problem because most of the weight of the lens relies on a single point, and then you create a negative refraction. And I totally agree that it's unacceptable. But the other point is to differentiate absence of fluorescein from quenching. From time to time, depending on the tear flow, depending on the tear exchange you'll get under your lens, you can have quenching of the fluorescein. That doesn't mean, as Brooke said, that you don't have any fluid. So the best way to assess, even today, this is my favorite one, to assess the limbal and the overall clearance under the lens, is to use the OCT to measure exactly what's going on there, because through the slit lamp, that can be confusing sometimes, especially for practitioners who are not really familiar with scleral lenses, and even those who are familiar, that can become a challenge at a given point. So OCT is the way to go, no question.
Thank you. And Jason, what are your thoughts?
Well, if you don't have an OCT to check limbal clearance, and a lot of people don't, I think that my preferred way to assess limbal clearance is to place the lens on the eye with fluorescein, just like we would assess the fit, to use a broad diffuse illumination, cobalt blue light, and absolutely you have to use a Ratten filter. And again, as Brooke mentioned, you should see fluorescein extend just past the limbus area under the lens. Now, and so that's, you know, I don't see any value in taking a slit beam and of optic section of white light and looking at the limbus. I don't think you can see it well enough. I would like to just say that I'm not convinced either that limbal clearance is completely necessary. I think harsh limbal bearing is unacceptable. But I think if you have a lens which is clears the limbus at dispensing, and we know we're going to lose a little bit of clearance with time, I think if that lens gently rests at the limbus, I think we probably are okay. It's just when we get that tight compression that we can run into problems. So if you've got fluorescein getting underneath there that you can see with diffuse illumination or rat and filter at dispensing, usually I'm pretty happy with that and knowing that you'll lose a little over time.
Thank you, Jason. I think that was a really useful comment and observation. Thank you. And Brooke, I'd like you just to kind of go over what we're seeing here with the OCT and just kind of explain this picture.
Okay, so looking at the center, the OCT picture, we have at the very top we have the lens, and then there's a middle layer, and that's our tear layer, and then underneath we have the cornea, and then all the way back, obviously, we have the iris. And where the iris meets the sclera and where the red arrow points, that's where we have the limbus. And so we would want to see the tear layer between the contact lens and the cornea extending out past the limbus. And so here, if we were to now look at the colored pictures, starting on the left side, it would look like, you know, we're losing our tear layer out there, which corresponds to the picture here, where we have the clearance under the lens, and you can see that it doesn't quite make it out to the limbus. And then as it moves forward centrally over the cornea, we can see that we gain some thicker clearance centrally on both sides, both the picture you're pointing at there and then on the right side also. And then we have the optic section extending out to the right side of the iris there. And according to the OCT, it looks like we don't quite have enough clearance, you know, to reach out past the limbus.
Thank you, Brooke. And Longis, would you please explain this picture of the OCT?
Yes, it's a colored one, so about the same thing. You have on the upper green, between the two green bands and the black space, this is the lens, the contact lens itself. And then just under the lower green band, you have a space between the cornea and the lens, which is filling with the fluid. It's the tear reservoir. And you have the limbus that is just under that. So you have a limited amount of clearance here compared to more centrally. But I totally agree with Jason that if at the delivery you have enough fluorescein, you know, flushing out of the limbus, it's no concern. And over time, even if you have a limited clearance at delivery, the lens will rest just gently. As long as you don't have a significant staining over on the cornea and nor any compression ring when you remove the lens, it's not a big concern for me. Certainly, if you're not happy with that type of clearance, you can expand your lens and or to modify your mid-debris. Ask your lab about, you know, modifying the reverse curve of the lenses so it will vault a little bit over the limbus. But again, you have to be cautious about not over vaulting the limbus to do not create a harder landing on the conjunctiva and then fogging with the lens and other physiological issues. So there's an equilibrium between the landing and the vaulting over the limbus, certainly. And when you have a limited clearance, and this is a perfect fit you can have with that patient, you can also use more viscous solution like Refresh Elovist. We lose less compared to non-preserved saline, and certainly it protects more the epithelial cells in the ocular surface. So that's a better choice and wiser choice if you have limited clearance and certainly have nothing other options to fit that patient.
Thank you. And just a couple questions before we move on to our last topic. Does steepening the PC a little lift the lens off the limbus?
Depending on the design, you know, it's all equilibrated with other other peripheries. Some manufacturers will suggest that. Other manufacturers, depending on their design, will say that if you steep the PCs, you'll increase the overall clearance, which is probably not exactly what you want. And the more you're vaulting over the cornea, depending on the size of the lens, you can create a heavy landing on the conjunctiva, which is not appropriate as well. So I think the best way to answer that question is to ask the lab about their specific design and how they suggest in their fitting guide to address those issues.
Yeah, I think ideally, if you have a good landing on the sclera right now, but you feel you need more limbal clearance, you don't want to compromise that nice area of scleral bearing just to get that limbal clearance. You should be able to steepen the curve immediately peripheral to the limbus to get the maximal benefit in clearing the limbus without affecting the fit outside of that.
Thank you. So let's go on to our last topic, which I know is something that is very important among the scleral lens community. So what I'd like to do is I'd like to limit the panelists to about 3 minutes per person. Can you just answer any of these questions that you see on this slide and just kind of tell us your experience? And I'd like to start with Brooke.
So I'll take a couple questions here. How are the costs discussed? The costs are introduced to the patient with a specialty contact lens contract, and so the front office staff will present the patient with a contract just outlining, these are, the charges that are associated with our specialty lenses, and you may fall into one of these categories. And then in the actual exam room, I will outline to the patient what category they fall under, and then based on that, what costs they can expect. I go back and forth personally if I should discuss these costs with the patient or if I should have a member of my staff. But ultimately, the patient ends up asking me, and so I feel, I feel very comfortable just presenting the costs as they are, and then presenting them with the payment options or how we handle insurances and things like that. Because I think it's very important that it is presented up front so that there are no questions going forward or assumptions going forward as to how the payments will come around, and so that and also so that the patient knows that if the insurance declines them, that we're on their side, we'll help them appeal, but ultimately some costs may end up on their shoulders. I'll take the payment plan one too. We do offer some, we try to break it up into no more than thirds. That's our policy now, and so if they can put down some at the fitting, and then some at the initial lens dispense, and then at the follow-up, everything must be paid for. And that's our policy here in Minnesota, where everybody's nice and it's easy to talk to everyone.
Thank you, Brooke. Jason, what are your thoughts on the financial side?
I think it's important, as Brooke said, to mention the costs up front. I feel like scleral lenses do a lot of the selling for me, though, and so if I know I have to go down the road of a scleral with an individual because of their history dictates that they haven't been successful in other lenses, and we know we're going to put a lens on their eye, and once we get a lens on their eye and they see how comfortable it is, what their visual potential is, and what I'll usually say at that point is I'll explain, now the cost for my time to work with you and fit you with these lenses and to do your exchanges and your rechecks is X amount, whatever you decide is an appropriate amount to charge for a fitting fee. And this fitting fee is non-refundable. If I'm going to see you and fit you, no matter what, these are the charges for my time, and people understand that. And then we explain what the cost of the lenses are, and again, they're usually very happy with the feeling and the vision, and so when we talk about the cost, we don't get a lot of pushback. However, there are situations where people do have a concern, and in those cases we can talk about, well, we can submit to your insurance if you wish, but I'm not going to order you lenses until we've either gotten payment from your insurance then or some kind of guarantee that it's paid, or you've set up a payment plan for your lenses, because I don't want to order anything that I have to pay for without some idea of where the payment is coming from. We do utilize insurance for patients, for those companies that we are a provider for. And if patients don't like their scleral lenses, most labs have a very generous policy as far as cancellations or returns within 90 days. Again, I'll just make it very clear up front that my fitting fee is not refundable, that no matter what happens that will be owed or paid, and that the cost of the materials themselves could be refunded if they returned within the warranty period once we receive our refund for our cost.
Thank you. And Longis, do you have any final thoughts? And I'd like to end the webinar with some rapid-fire questions, so if you could answer in about a minute or two.
Yeah, I'll try to do it. It's a little bit different in Canada compared to the States, but we try also to charge more for our fitting fees compared to the cost of the goods. And for the follow-ups, habitually, our fitting fees are including for free 2 to 3 follow-ups in the weeks following the initial fit. So obviously the professional fees are a little bit higher. And again, we have to be very, very very realistic about the success rate that we should have. At the dispensing, we can reach 90-95% of success, but based on Dr. Shornack's studies at Mayo Clinic, and after 6 months, probably 60 to 70% of your patients will remain in scleral lenses. So that means that 30% had to be fitted with other means, so that have to be counted in your cost. But the question will be certainly crucial at this time when we see that scleral lenses are becoming more mainstream, and we will target regular patients with normal corneas. These are patients that are not really paying a lot of money for their lenses eventually, so that will be a challenge to introduce them. If they see the difference in comfort and vision, they'll get the lenses, but this is the challenge that we'll have.
Thank you very much. So I'd like to end the webinar with a few questions from the audience. So if you have any questions out there, please type them in. If you want a specific doctor to answer the question, please put their name so I know who to direct that to. And if you could, doctors, if you could just keep your answers just very quick and just the basics, that would be great. So Dr. Messer, what about using Celluvisc in the bowl of the lens?
The one thing there to keep in mind is that it is a thicker solution, so it may cause some blurring. But Celluvisc is great for use when you're concerned about lens settling on the apex of the cone. And also to reduce some of that tear exchange if you do have some, in the interim of your fittings. Using Celluvisc in the bowl of the lens can limit some tear exchange.
Thank you. Longis, do you have many fits going beyond the 90-day lab warranty?
Hopefully not. Hopefully not. With experience, the learning curve is quite fast habitually. With smaller lenses, 15 millimeter or smaller, 5, 10 patients at the most, and you'll do your fits very, very accurately within the 90 days warranty. With larger lenses, because we have to deal with toric peripheries, obviously it takes a little bit longer, but if you get the patients, actually it's not an issue, not a problem.
Thank you. And I'd like to ask Jason, how do you charge for follow-ups after the initial fitting? How many follow-ups are included in the initial fit and cost?
We typically include the visits within the same time frame as the warranty on the lenses. So if we're doing fitting, it's fairly unlimited for the 90-day period. Once we get beyond that, we may charge an office visit. We may talk about charging another fitting fee if necessary. It depends upon where we stand. Again, I think that making sure the patient is aware of that 90-day window for exchanges, and also if you can have the patient paying for their lenses on the front side, they become more involved in getting in for follow-up as needed and exchanging if needed. So I mean, you have to bill, you also have to explain that up front, that this covers 90 days of care and lens exchange, and beyond that there can be additional charges. If you put that out there at the very beginning, it makes it much easier to deal with it when you get down to that point.
Thank you.
I have one comment there.
Yes.
Make sure that if the patient comes in, you separate the contact lens care versus the red eye. If they come in with a red eye during that 90 days, it's an office visit versus if it's related to, strictly contact lens evaluation, and that's your policy, then, that's allowed, but red eyes are a separate visit purpose.
Thank you. And are any of the speakers using the 92072 CPT code for keratoconus initial fit, and are you including 90 days of care with that code?
I will use it if I'm going to submit to a medical insurance. If we're using a vision plan, which gives us global fee coverage, I don't use that code. If I use that code, it covers the initial visit, and each subsequent visit is billed out as an office visit going forward.
Thank you. And the last question, which I think is a really interesting one, from Dr. Shea. Why do you think there is such a difference in insurance reimbursements? What are industry leaders doing to bring this discrepancy?
Yeah, that's a great question, and we could ask that about a lot of things in all of medical and vision care. I am not aware of anybody doing anything to try to modify it other than some of these new organizations which are trying to come together and essentially form a union-like organization for the purposes of negotiating with some of these poor-paying plans. I think if we want to do it, it has to be grassroots. I don't know that we can count on just our leaders. I think some of the organizations that are forming can make a difference, but we have to come together and everyone has to get involved.
Any comments, Dr. Messer, Dr. Michaud?
That's a really tough question, and it is hard to, in the office, it's hard to set appropriate fees when there is such a discrepancy in trying to make sure that everything is, equal across all patients, but the insurance discrepancy is so tough. Ultimately, and I learned this from Dr. Jedlicka, is that, the patient comes first, and regardless of reimbursement, you just have to care for everyone as if, you get the same, and continue to educate. I do call insurances from time to time to help in a patient with an appeal, and so I don't know if any education gets through in that regard, one person at a time, but I am willing to do that from time to time.
Thank you so much. And thank you all so much for attending and supporting our Scleral Lens webinar. And I'd like to thank Drs. Jedlicka, Messer, and Michaud for their expert opinions and donating your time to this webinar. Don't forget to go to sclerallens.org. There's a newsletter that goes out about once a quarter telling you about new updates on scleral lenses and what's going on in the industry. Also, if you visit our website, there's an opportunity to become a fellow, and when that happens, you are added to our Scleral Lens Fitters page, and patients can actually search you out along with fellow doctors. So thank you so much for your support, and we really hope to see you on the next Scleral Lens webinar. Have a good night.